And so let's move on to the next speaker. So the Professor Myung-Ki Hon. The title is Stent Optimized After Class 1A Indication of Imaging Guide PCI in 2024 ESC Guideline. Yes, please.
Thank you, Chairman. I'm gonna talking about the stent optimization after the Class 1A indication of imaging guided PCI in 2024 ESG guideline. My disclosure. As we know, the current guideline 2024 or ESG 2025, the American guideline recommended the imaging guided PCI in the complex region and the left main region. Before the 2024, I present two suggestions. First one is do a imaging guided PCI for complex lesion. Actually, this is now recommended in the 2024 ESC guideline. Second suggestion was do our best to achieve optimal imaging criteria. Actually, stent optimization is a really matter. 2015, the IBS XPR study clearly showed that the clinical outcome is different between the patient who meeting the IBS criteria for stent optimization versus those not meeting the IBS criteria for stent optimization. This finding was again demonstrate that the ultimate trial, which was published in the 2018, there is a clear difference. Actually, the difference was driven by the soft endpoint reduction of the TLR or target vascular revascularization. What about the hard endpoint? When we accumulate the patient level data with the IBS-XPL and the ultimate trial to evaluate the 3-year hard clinical outcome, in viewpoint of the cardiac death or composite of cardiac death or MI or stent thrombosis, the stent optimization is really working. This finding was again was demonstrate the Renovate complex PCI trial 2 years ago, which was published in the New England Journal of Medicine. And this finding was more prominent in the complex lesion, really complex lesion. Typical example is a CTO lesion. This is so famous. The European expert consensus for stent optimization was suggested in the 2018. There are lots of the variable to define the stent optimization, minimum stent cross-section area, model position, and tissue prolapse dissection, and the disease in the reference vessel disease. However, in the practically, many of the interventionists say that there are too many factors to remember in the on-site to the procedure. What is among those variables, what is the most powerful factor to remember is that most consistent and the strongest parameter to predict the clinical outcome is a post-PCI minimum stent area. This is a summary of a definition of the stent optimization in the landmark trial, IBS XPL Ultimate, and the Renovate Illuminate 4, IBS ACES October, and the Occupy trial. The definition is too much, and the value was so different. Which one we have to use it? Too complex. Therefore, among them, how we define the most post-PCI minimum stent cross-sectional area. Traditionally, there is the 7 different criteria as the absolute criteria minimum stent cross-sectional area more than a 5 or more than a 5.5. Relative criteria is the more than 80, 90, or 100% of the distal reference lumen area, or the 80, 90, more than the 90, then the average reference lumen area. We actually achievement of this kind of the stent optimization criteria is difficult. Almost be half of the patient achieve it. The remaining half of the patient did not achieve. Among them, what about which definition was achieve a statistical significance to discriminate the clinical outcome at 3-year follow-up from the IBIS XPL and the ultimate trial? Only 3 the criteria. minimum stent cross-sectional area more than a 5.5 or 5 as a relative criteria, minimum stent cross-sectional area more than a 90% of a distal reference lumen area. The other remaining four criteria did not achieve a statistical significance. Recently, the IVS ACS trial was published in the Lancet. We re-evaluate the impact of the IVS guided optimal stent expansion and 1-year clinical outcome. When we defined the primary endpoint was a target vessel failure, it was consists of the two factors. The hard endpoint was the cardiovascular death and MI, as well as a soft endpoint as a target vessel revascularization. The only absolute value minimum stent area more than 5.5 achieve a statistical significance. The minimum stent area more than a 5 does not achieve a statistical significance. When you look at the right side, the event curve in the Kaplan-Meier curve, red color is a suboptimization, green color is a optimization. When you look at the minimum stent cross-sectional area 5.5, so there is the curve was the early separation at the 3 months. And the minimum stent cross-sectional area more than only 5.5, there was no separation of the event curve at the earlier between the 3 months or 6 months. It's a late separation. Therefore, the actually 1-year target vessel failure regarding to the this finding, only minimum stent cross-sectional area more than 5.5. Actually, the achievement of this kind of the stent optimization criteria is around the 60 or 70%. When we define the hard clinical outcome, only cardiac death or cardiovascular target vessel related myocardial infarction, only minimum stent area more than 5.5 is the achieve statistical significance. Minimum stent cross-sectional area more than 5 does not achieve a statistical significance of a stent optimization to discriminate the hard clinical outcome. This is the Kaplan-Meier curve based on the hard event. Is a similar finding. What about the correlation between the IVS versus the angiography? Theoretically, area of the circle, MLD is the 3O, is the theoretically we calculate the pi r square is around the lumen area is 7. 2.75 is by QCA is a lumen area is around 6. When the MLD is 2.5 is the lumen area is 5. So IVS by the 5.5 is the position is between around the 2.65. Ladies and gentlemen, this is my conclusion. The most simple and important parameter to the imaging guided PCI is only one, minimum stent cross-sectional area by IVS more than 5.5. Please remember this one. The other, the presence of the malposition, edge dissection, tissue protrusion, and the reference vessel is how much it is. It is maybe working, but minimum stent area more than 5.5 is a top priority. Please, simple. This is a very simple. Remember this one. Thank you.
Thank you, Dr. Hon. So, very wonderful lecture and also a very simple message for our audience. So, are there any question or comment?
Thanks. Does it matter whether the artery is left main or not left main? I mean, so we thought left main you need a higher value. So does this apply to all arteries? Actually, this is from the IVS XPL Ultimate and the IVS ACS data is a whole coronary artery, but in the proportion of the left main, this is smaller. As we know, Dr. An's data is only for the left main. I remember that 6, 8, 11. We have to remember specifically in the left main region.
Any other question?
Yes, I think the 5.5 square millimeter is very easy to achieve. If the vessel is quite big, like 3.30, but the vessel usually tapering from proximal to distal. So you one of your last slide is mentioning about the pi multiply with the radius of the vessel. So do we need to adjust the criteria for the vessel like a proximal, mid, and distal vessel in order to get a good result? Because if we have to go to achieve the 5.5 with the vessels quite small, so very dangerous for the vessel if I get cause a dissection at the distal edge or something like that. So what do you think? Thank you.
Okay, very good question. Actually, to achieve more than a 5.5 in a small vessel is clearly is impossible. Impossible. Therefore, we need the another criteria as the kind of the relative criteria, less than the more than the 80 or 90 or the 100% of the distal reference lumen area. Therefore, we evaluate and validate such kind of the relative criteria in the small vessel, and the distal reference diameter is around 2.5 or 2.75 using the IBIS XPL or the Ultimate and the IBIS ACS data. Finding is that such kind of the relative criteria does not working. It means it does not achieve a statistical significance. What does it mean? If we treat the small vessel disease around the 2.5, we do a stent, we do the balloon, or we do a drug coating balloon, what about the outcome? It's a similar. Even in the medical treatment, clinical outcome is similar. So in such kind of the situation, what is the meaning of the stent optimization criteria of the small vessel disease? Is useless. Is that the it means a small vessel disease, whatever it is not predictable. Just let it alone.
Can I ask? That's great talk and very clear message. One number 5.5. How do we apply that to OCT? It's got to be a smaller number, right?
Right. In the aspect of the OCT, it needs a validation. What I mean is, there is a lot of the data, even in the IVS alone. The most of in the registry based data. Therefore, it is a really we can we have to remember from the such kind of data characteristic is not high valuable. Therefore, I use it only for the random data. What about we have to when we evaluate the OCT, we have to accumulate all random data and validate and try to what is the value of the. Actually, in the European consensus, they recommend 4.5 by OCT and 5.5 by IRIS. But actually, how do they suggest it? There is no evidence at that time. Just expert recommend that. Do you have any strong data? No. So in regarding to the OCT, it is in need of the validation using the high quality of the data.
Okay, so thank you, Dr. Hon.